So I'm here with Dr. Ryan Goodmanson, one of our outgoing fellows. Go ahead and step in here. Yeah, there he is.
Howdy.
He's going to help me out today.
One moment.
And so just a few things, if you could come down to the field here. We've kind of prepped out and done the beginnings of our perk screw. So if we could move the camera down onto the field, there we go. So if you back out here, we basically just took the same setup from the lateral and put these in. When we're not concerned about sterility, it's not really a big deal. But one of the things you really want to be aware of is you can see here this table is very close. We're able to get these in, but we were very close to hitting this table, which would have really altered our trajectory. So if you don't have a table that actually turns, you want to make sure that you have the patient positioned all the way up to the edge. So that will give you more range. You may have to lift the table up so that you're not coming down out of sterility. When you're doing these bottom screws are really the ones that are challenging. Some of the tables that can actually turn make this much easier. So if you can really stabilize the patient, have them in a lateral position, turn them just maybe 30 degrees, it makes the whole procedure much easier rather than having to come in at an angle like this. You're just coming straight in, and you can even do that after you put in these top screws. So we've done a lot of the work ahead of time here, but really that's the main thing with the single position lateral is that you want to make sure that you're not going to kind of drape yourself out or have any problems with not being able to hit the appropriate angle.
And Amir, do you have any preference on whether or not to do this lateral first and then the screws, or the screws first and then the lateral?
So theoretically, I like the idea of getting my reduction of height first. I think that was really interesting earlier listening to Larry's talk, how he talked about doing a little bit of both. I think that would give you even more control, especially when you're not taking down the facet completely ahead of time as you would in an open approach. But I usually, in my workflow, want to do my lateral first, try to get some height back, and then compress across that fulcrum posteriorly afterwards. So go ahead. Give us a shot there. So we've got our first 3 wires already in. And go ahead and come across to an AP. And if you can just see here, another thing with the lateral is that putting in perk screws from lateral, your radiology tech is a huge part of this case. So if you can do a dry run ahead of time, just going through the workflow, that can save you a lot of time, because the time that you save not flipping, you may lose having to do a whole lot of different shots, especially if it's at a 30-degree angle. Just having a radiology tech who's kind of familiar with that ahead of time. So we're getting our starting point at that lateral aspect of the four-pedicle here. And always want to make sure as we're coming in with the AP, once we've gotten in, we're still lateral to that medial border of the pedicle. Okay, and we can see here that we're still well back away from the vertebral body. So as we come up right to the edge of the vertebral body, keep coming in. There. Great, we should be right at the edge of the body there. And then we're just going to check another AP to ensure that we haven't violated that medial wall.
I went through the body, sorry.
Yeah, so a little bit deep there, but again, you want to see that tip of the Jamshidi needle just at the medial aspect of the pedicle once you've gotten up to the, he's going to back it up just a little bit to demonstrate.
Shot there.
Okay, great. So from that position, now come back to our lateral.
And Amir, what type of table do you use? Are you breaking the bed at all? And are you using like a Wilson or gel? Like, what's your setup for these?
So I've never gone out on a limb and actually done it. I have done a couple times, but that was back in residency. and definitely have struggled in different ways. I've seen the Wilson frame used, which gives you a little bit more support if you're on a table like a standard bed where you're going to actually be able to turn that laterally, and it gives the patient a little bit more support so they're not falling off the table. You can use the gels or, it's kind of dealer's choice, but you want to make sure that you do those shots ahead of time to know that you're actually going to be getting them correctly, and then also that the patient's not going to be falling off the bed. But I would use a Wilson frame with just a standard bed so you have that lateral twist to it.
Got it. Thank you.
X-ray. We'll put screws on.
All right, so we're going to go ahead and put some screws in now. And, with this one, you can see if we back out really just the angle that we're placing them in, pretty easy from the top. The bottom half, we may run into a little bit of a challenge, and that's what we want to look out for ahead of time.
X-ray.
Okay. And one of the things, make sure we're collinear. Can even move this guide wire a little bit within the cannulated screw to ensure that you're not going to bite into that wire. And so this is fairly osteoporotic bone. We're not doing any sort of tapping here. Shot. Okay, coming down nicely. And I'm just checking again to make sure that the wire's free. Mm-hmm.
X-ray.
All right, we're down there, and this is probably the point where you want to pull this wire to ensure that you don't bite into it.
Sure. X-ray. X-ray.
So what parameters do you use to know that the screw is deep enough?
I like to, if you have a kind of ratchet mechanism, you can actually feel, rather than putting it all the way down on power, you can put those last few turns by hand.
Got it.
And know that you actually have that tactile feel. Whereas if you're just using power, you can either not put it down far enough, or you can kind of break that pedicle or really mess with the track of the screws and lose your bite there.
X-ray.
How about you, Jeff? What do you feel like is a good indicator for you?
I agree with you. Like the last few turns, sort of by hand, because the power can actually, you can either do one of two things to the screw. The screw can, in really osteoporotic bone, it can actually kind of drive it forward.
Yeah.
Beyond the posterior elements. But the other thing it could do is it could get stuck at the junction between the tulip as well as the dorsal elements, and then it'll essentially just core out the vertebral body. So it'll act as a post and not a screw. So where you have that first screw is almost perfect, where the bottom of the tulip is really adjacent to the SAP, and you can see that little area is almost exactly where I like it to be. So for this, I'd probably maybe, if you wanted to, you could probably go in another couple of turns, to seat it, and I'd probably, and then just like what Ryan is doing right now, sort of make sure that the tulip heads match up.
Yep. And that's also another consideration, when you're making your skin incisions in a single level, not as important, but always want to look at that cascade of the incisions, because it's going to really challenge the placement of your rod if you have to go through it. Even in a two-level case, if you're trying to go back and forth, it's going to be really difficult with the perk setup.
Who put in that cage? That looks great.
I know, right? Looks like we might have gotten a little subsidence there.
Yeah, right.
Shot.
Way to go, Ben.
X-ray.
So Ryan, what are you feeling there as far as like from a tactile sensation?
Yeah, you can kind of feel it engage as it comes down into the pedicle. So you'll feel it go through the cortex kind of right at the starting point, like where we feel the mammary process is supposed to be. And then you'll feel it get a little bit loose as you go through the pedicle. But then as you hit the body, you feel a little bit of resistance. And then as we get in further and the tulip head gets close to the IEP there, you can start to feel even more resistance. And so then I'll take a shot and we'll see if we're down or not. These screws are a little short, but that's what we have.
Maybe just a couple.
And then
more
if we
turns.
want, we can try and do a hand turn here just to make sure that we're feeling, give a stab and grab or.
The screws are looking great.
I will say that lower screw, yeah, so that's a good feel there. Shot there. That lower screw trajectory is difficult. I haven't done these for a while, and we don't have a robot, so we are the robot. But getting your ML is a little bit more difficult in this position, just the feel of it. Shot there. Shot.
And you guys did a really nice job of placing those incisions, but I've also found that if you don't position it well,
Shot.
and there's skin that's sort of folding there, and you make the incisions, you'll end up with very asymmetric incisions left and right.
And so, hold on, this is actually a
can see
good
it
point
happening.
here. If you can focus in here on the skin, we're actually kind of catching the skin a little bit.
Oh yeah.
And that's something that can definitely really hurt one of your screws because, especially in osteoporotic bone, if you're pulling against skin or fascia, that's going to cause the screw threads to core out the trajectory rather than biting in and keeping grip.
That's a
So
really
we
good
just
point.
adjusted the skin there, and we're going to keep going down.
Sure. Thank you. Sure. Can I have that handheld? Shot there.
And so we can see from that lateral, we've got a nice concordance of the screw heads. Should
Invest
help
in an
us out.
AP. Make sure my medial lateral was on.
Pretty
Looks
happy with
great,
those.
guys. I love that. The symmetry is great. I love on the lateral that it's parallel to the superior end plates. And then when you take a look at left and right, you can really see that it's like a mirror image of each other, right?
Yep.
Especially at the 4 screw. That's almost like a perfectly placed screws bilaterally at that level. They look really nice. Nice work, guys.
We have great fellows here.
He did those wires. I did the bottom ones. That's why that one's going.
Great. Anything else?
We're just going to go ahead and place the rod in.
Cool.
Again,
Great.
you know, we've got a little bit of time here, so.
So any tips and tricks with respect to putting in the rods in this lateral position?
So one of the things is making sure that you really get that tip of the rod down first, because one of the things that I've seen in some other cases is trying to basically put that rod in suprafascially, and you get stuck and you really drag soft tissue down into the actual screw tract where you're trying to have, you know, your construct, and sometimes it won't go. So that's definitely something that I've seen. And you know, you can put these in from the top or the bottom, kind of what kind of feels better for you, but really getting that tip down into the tract first and then turning. And once you get down, you should actually be able to see that this head right here is no longer able to turn. So that'll give you an indication that you've made it into the trajectory. And so you're heading low.
Yep.
And so just try and maybe rotate this up a little bit. So it's going to be a little bit up towards the sky.
Hey, Amir, can you talk about using straight rods versus gap rods in your preference?
A shorter rod.
Sorry, I can't hear that.
So what about using gap rods?
I think the question was straight rods versus curved or pre-bent rods.
So yeah, obviously it depends on the area of the spine. We're using a lordotic rod here. As we're in the lumbar spine, we do want to keep that lordosis. And then also, as we've got that nice anterior graft, as we compress, we want to be able to bring it down. So I tend to use lordotic in the lumbar spine. If you were at thoracolumbar junction, for instance, in a trauma case, you might not need it.
Just trying to get my rings back on.
And so, Ryan, how are you confirming that the distal aspect of that tip of the rod is within the L4 blade?
Actually, just visualization. I can see it
Got
right
it.
now. As you come
You
down,
may be able to see that with the camera too. You don't always see this intraoperatively, but we've actually got a nice view here. If you kind of turn this down, you can actually see it right there. So if you move back and forth, that's actually the rod that's down. And this is fortunately a very thin patient. If you've got a deep hole, you may not be able to see that, but that's the rod. And then you can see that this
Oh yeah, you can
won't
see it.
rotate.
That looks great.
Okay.
shot there. Shot there.
Perfect.
That looks great, guys. There's
Yeah,
a question about unilateral versus bilateral screw placement, because I think there are some surgeons who place in unilateral screws at the top, but don't do it on the bottom because of the fact that you're going from bottom to top.
So one of the things that, there is a study out there, sorry I don't know the author, if anyone out there can remind me, but there have been some cadaveric studies that have shown that if you have unilateral screws and a plate with screws on the contralateral side,
Yeah, I just wanted to
that's
move it down.
similar in construct strength to having bilateral perc screws. But again, in order to get that stability, you want to have the lateral with the screws coming in this way, and then from the opposite side, the perc screws. So if you're doing all on the same side, that's not going to be as strong of a construct.
So meaning that you want screws on the contralateral side of a TLIF, for instance?
No, so if you're doing a lateral cage with screws and a plate,
Oh, I see what you're saying.
that's similar strength to a bilateral perc screws.
Got it.
But if you're doing a screws and a plate and ipsilateral screws percutaneously, that's not as strong of a construct.
Got it. But then that would mean that you would need to put in the screws on going from bottom to top, right?
Exactly,
From
and
floor to
those
ceiling,
are the challenging
the
screws.
difficult side.
Yeah. So with image guidance, that does help quite a bit because you can raise the patient up and you can place those screws without having to worry about the imaging and the table as much. But it is possible if you plan ahead of time. So give us a shot there. All right. And so we've got our construct there. We also want to maybe do a little compression.
I gotta loosen the.
And if you were to really want to be getting compression here, I would recommend we haven't done a facetectomy, but even just a small facetectomy bilaterally would allow you to get a little bit more compression there and continue to work with that lordosis that we gained with the cage.
A question from Robert Huang. How do you decorticate MIS?
So you need to do tubular decortication. So you can place a tube down, and sometimes you can see where we've got our screw trajectories. You can make one of those a larger incision and place a tube and actually look at the facet and really either with a drill or with an osteotome, take down that joint, and you can place bone graft in there. Some people will do it with some of the modular systems where you've just got the screw head without the tulip. That gives you some more room. Or you could do it ahead of time, or you could do it with just the wires in place. So this is just kind of demonstrating we have the compressor there, and it gives you a fulcrum to kind of compress along MIS. Obviously, we're not going to gain anything here because we don't have that facetectomy done. But this device here will give you a fulcrum to kind of compress before placing those, locking those screws down.
We don't have the right final tightener. So I'll be the final tightener. There you go. I have to loosen this one though, right? Yeah. So that's loose.
So you guys are trying to compress to try to get a little bit more lordosis.
Yeah, and just going through the technique here, again, you would need to
Back
do
up
it
a little bit.
with the facetectomy at the
Just a
very
little bit.
least. But you can see by locking the back here, you can place this compressor in and we'll actually squeeze across those two screws.
Nice.
And so we've got one of them locked. We'll compress down. Give us a shot there. One more time.
Oh yeah, you can see
Yeah,
that.
absolutely. And
That
go
looks
ahead and
great.
lock
Look at
it.
that lordosis, guys.
All right, and that's really the
back up a
workflow
little bit
for
again.
our single position lateral. Really, I think the main thing in doing this technique is getting the workflow done ahead of time. I'm still gathering the courage to do it in an actual patient, but I think it's a great technique if you do have the right people working with you.
Well, Amir, you made it look so easy. You got to do this on a regular basis.
I'll let you know how it goes.
Okay, sounds good. Nice work, guys.
Thank you.
Really nice work.